Thank you everyone for joining us today. My name is Roberto Bernardo. I'm from Indiana University. And on behalf of the Pulmonary Circulation Assembly Journal Club Working Group, thank you all for taking time on a busy Monday to join us for this very exciting webinar. This webinar will be discussing a relatively recent paper by Sandeep Sahay that was published in the Blue Journal, Contemporary Treatments of Pulmonary Arterial Hypertension, a US Perspective. This manuscript will be presented by Divya Verma. Dr. Verma is a third-year Pulmonary and Critical Care Medicine Fellow at Emory University. After Dr. Verma's presentation will be this will be followed by a discussion with the panelist group. For the panelist group, I'm very lucky to be joined by Dr. Sandeep Sahay from Houston Methodist. He's the first author of the manuscript. Dr. Sahay is also with two of his co-authors. We have Dr. Murali Chakinala from Washington University and Dr. Ioana Preston from Tufts. And we also have two discussants, Dr. Jean White from Rochester University and Dr. Mardi Gomberg from George Washington. A few housekeeping rules. So any questions that you, the audience, has, please write them down on the chat box and we will go through them. Or you can use the hand raise icon on Zoom and we can let you speak about it. And with that, I think we can go ahead and start. Dr. Verma, the floor is all yours.
Thank you, Dr. Bernardo, and thank you guys for allowing me to come and present today. I am very excited to get to hear directly from the authors of this very interesting paper. So again, this is the article that we'll be discussing, and the full list of authors is here as well. I'm excited to hear directly from a handful of them. The paper we're going to be reviewing today is this one that basically is a review of treatment strategies for pulmonary arterial hypertension, specifically in the United States, from the perspective of several experts. As Dr. Bernardo said, it was published in the Blue Journal in September of this year. So my role today is to briefly present the paper to you all to discuss or to kick off a discussion with some of the authors as well as our expert panelists. I'll be using the structure of the paper to guide my talk. So we'll start with the current approach to the treatment of pulmonary arterial hypertension in the United States. So as we know, PAH is defined as precapillary pulmonary hypertension due to smooth muscle and endothelial proliferation and narrowing of the pulmonary arterioles, with the hemodynamic definition listed there as well. Most recent estimates quote a median survival of about 7 years after diagnosis. There are 4 currently approved drug classes in the United States. And thinking about the landscape of PAH therapy today, there are some specific barriers that are present in the US that kind of keep us from being able to improve that median survival. Some of those things are a disjointed healthcare system, challenges with insurance coverage, and a high prevalence of comorbidities in our patients. So the authors start by reminding us that PAH is multifactorial and complex, and that there are several different potential pathways that have been identified that contribute to the pathogenesis of PAH, all of which could potentially be investigated as targets for treatment, and several of those pathways are listed here. They include this kind of classic diagram of the pulmonary arteriole and endothelium, where they illustrate the classically described 3 pathways for our more longstanding treatment options: the prostacyclin pathway, the nitric oxide pathway, and the endothelin-1 pathway. But then, of course, also include the activin signaling pathway. So as we know, sotatercept is the first activin pathway modifier that acts as a ligand trap for members of the TGF-beta superfamily, and helps to restore the balance between proliferative and anti-proliferative pathways that favor proliferation in PAH. Next, the authors talk about PAH treatment in special populations. So they start by acknowledging that there is often significant difficulty in distinguishing who has group 1 disease with comorbid cardiac conditions versus who has group 2 disease, as this has considerable impact on treatment strategies. They start by identifying these cardiac comorbidities. This includes diabetes, hypertension, coronary artery disease, AFib, and obesity. They recommend a thorough evaluation of patients with suspected heart failure with preserved ejection fraction using right heart catheterization in the setting of either exercise and/or fluid challenge, where the goal is basically to unmask left ventricular diastolic dysfunction by showing that the wedge pressure increases inappropriately under stress. They also recommend the HFpEF score as a way to assess risk of underlying HFpEF. They point out that the 2022 European guidelines recommend cautious initiation of monotherapy in these patients with cardiac comorbidities, with cautious consideration of dual therapy later on. But they say that the burden of comorbidities is much higher in the US population, which may warrant a slightly different approach. They go on to discuss the existing evidence for the treatment of patients with cardiac comorbidities. First, they discuss a post-hoc analysis of the AMBITION trial, during which the inclusion criteria were revised partway through the study to avoid inadvertently enrolling patients with Group 2 disease. This led to a group of 105 patients who met the definition of PAH but had 3 or more cardiac comorbidities. This group with cardiac comorbidities had a blunted, though still favorable response to therapies. The authors do acknowledge that they also had more therapy discontinuation due to intolerance. They then present a post-hoc analysis of Griffin, which on the other hand showed no difference in outcomes when separating the study cohort into those with 3 or more comorbidities versus 2 or fewer comorbidities. The authors then also discussed data from both the Compara and Reveal registries that did not show a significant difference in survival between comorbidity categories. They note that most people with cardiac comorbidities in Compara were on PDE5 inhibitor monotherapy, and these patients were less likely to tolerate ERAs and prostacyclin pathway drugs. Whereas the Reveal analysis that they discuss had a much more homogeneous distribution of treatments across categories. They conclude from this review that the evidence supports not withholding standard PAH therapies from patients with cardiac comorbidities. They then discuss patients with PAH and the lung phenotype as was described in a 2022 analysis of the Compara and Aspire registries that looked at classical PAH patients compared to PAH patients that had the lung phenotype, which was defined as a smoking history and a DLCO less than 45%, and group 3 pulmonary hypertension, i.e. pulmonary hypertension with a clear underlying parenchymal lung disease. This analysis showed that the lung phenotype patients were overall older, had smoked significantly more than the classical PAH group, and had normal or near normal spirometry. They were more likely to get PDE5 inhibitor monotherapy, were less likely to achieve a decrease in their risk status, and had a dramatically worse survival than their classical counterparts. The authors mentioned later on that these lung phenotype patients may be less likely to tolerate aggressive vasodilation, but recommend a personalized approach. And then finally, they talk about a treatment approach specifically for PAH in the US in 2024. So again, the authors encourage a personalized decision-making approach to each patient and discuss weighing the risks of the patient's PAH and the patient's comorbidity in each case. If they encourage trying to optimize comorbidities as aggressively as possible, but to fully consider the severity of the PAH before withholding treatment solely on the basis of comorbid conditions. And they emphasize that this balance can be different in every patient. And then finally, they conclude with a treatment algorithm that includes a few modifications compared to the European guidelines. So we'll take a few minutes to go through that. So let's pretend like we've seen a new patient with pulmonary arterial hypertension. First, the authors recommend that we risk stratify them using either the Reveal 2.0 or the ESC-ERS risk assessment tool. If your patient on initial assessment is low or intermediate risk, and then the authors recommend upfront dual oral therapy, which is consistent with the AMBITION trial results as well as the European guidelines. If at 3-month follow-up, the patient is low risk, which to assess this risk, they suggest using either the Reveal Lite 2 or the Compara 2.0 4-strata risk assessment tool. And if their imaging is without any high-risk features, then they suggest continuing dual oral therapy and reassessing in 6 months. If the patient has either stayed or improved to low risk clinically, but has intermediate or high risk imaging features, which are listed here, and they recommend looking at the ESC-ERS 2022 guidelines for this list of high risk features. Some that are included are severely enlarged right atrium or significant pericardial effusion. So if your patient has any of those, then the authors suggest that these patients should sort of then be upgraded into the intermediate low risk category. For both these low-risk patients with high-risk imaging features or patients that initially fell into the intermediate low-risk category after 3 months of dual oral therapy, They suggest discussing another agent with the patient, either a non-parenteral prostacyclin, sotatercept, or considering changing their PDE5 inhibitor to riociguat, and then following up in a closer interval of 3 months. And then if the patient is intermediate high risk after 3 months of dual oral therapy, then they suggest again considering an increase in therapy. This time they suggest a parenteral prostacyclin specifically and or adding sotatercept, and again following up within 3 months. Alternatively, if your initial evaluation leads to a high-risk designation at the start, or an intermediate risk score but with high-risk hemodynamics, which again, they recommend using the ESC-ERS definition for these high-risk hemodynamics, which are listed there. Specifically, I think a right atrial pressure greater than 14 or a depressed cardiac index. Then again, the authors suggest kind of considering an upgrade of intermediate risk to high risk based, again, on the presence of these hemodynamics. For this group of patients, they recommend initiating upfront triple therapy, including a parenteral prostacyclin, an ERA, and a PDE5 inhibitor, with reassessment at 3 months. If all of this is enough to bring the patient down to low risk status, then they recommend confirming that echo or MRI is consistent with improved risk, and then following a low risk approach. If the patient remains intermediate risk after triple therapy initiation, they suggest adding sotatercept and or uptitrating their prostacyclin as tolerated. They mention lung transplant evaluation specifically and recommend very close follow-up, so anything between 1 and 3 months. And if the patient is still high risk after triple therapy, then the authors are more firm about adding sotatercept and uptitrating the prostacyclin as able. They more firmly recommend lung transplant referral and close follow-up. So my last slide is just going to point out a few differences between this treatment algorithm and the 2022 ESC-ERS guidelines. So of course, we're now lucky enough to have access to a 4th class of drug in sotatercept. The authors suggest starting sotatercept on first reevaluation for patients who do not achieve low-risk status within 3 months of treatment initiation. I'm curious to hear from the authors, and I think this might be one of Dr. Bernardo's questions, if they think that this approach leaves anyone out, and also if there are situations where the authors would consider starting sotatercept at diagnosis. And then probably more kind of hot off the press, and I think we'll end up talking about this later, whether the Zenith trial results that just came out this morning, if that changes anything in terms of how you guys would approach the algorithm. The authors also suggest a more personalized approach to treating patients with cardiopulmonary comorbidities and concurrent PAH. As a fellow, I'm curious if there are ongoing discussions about how to more objectively standardize the diagnostic paradigm between group 1 disease with cardiac comorbidities versus group 2 disease with a significant precapillary component. What should we do also with patients whose phenotype may change over time with goal-directed medical therapy? The authors incorporate the REVEAL 2.0 and REVEAL Lite 2 risk calculators as alternatives to the European risk stratification system. And finally, they suggest using RV imaging at reassessment and severely abnormal hemodynamics at diagnosis as reasons to consider upgrading risk designation even outside of those scoring calculators. And that is what I have for you guys. I'm lucky in doing this journal club in that I get to turn the questions to the actual authors of the paper. So I'm going to go ahead and stop sharing and turn it back over to Dr. Bernardo.
Thank you, Divya. That was a great summary of the paper. Congratulations, Sandeep, Ioana, and Murali. This was a really beautiful paper, really provocative. So I'm going to start with some questions, but again, to the audience, any questions you have, you can use you can raise your hand and we can let you speak, or you can write down your question on the chat box and we can go through them. So Sandeep, let's discuss some of your comments on the paper. Unlike the recommendations from the European guidelines, you put some emphasis on hemodynamics and imaging, something that the Europeans didn't do as much. Where does this rationale of adding imaging for the RV comes from?
I think hemodynamics, first of all, thanks Roberto and the ATSPC Assembly to organize this webinar. To your question specifically, that if you're talking about the hemodynamics at baseline, it's actually from European guideline. It does say that if you have high-risk hemodynamics, you may consider those patients as high risk. As far as the RV imaging part, which we incorporated, I guess it was a general consensus among all of us that there are certain low-risk patients who, based on whatever risk stratification model you use, but their RVs do not look good, because eventually our goal remains that as much as we can normalize their RV function, hoping to improve their long-term survival. And that's why we incorporated it's actually more of a suggestion. You may consider that as, and we use the table from the ESC ERS as what defines as a low risk imaging versus intermediate and high risk. But yes, our paper just puts it into more central in this algorithm that RV imaging can be used. I'll let Murali and Ioana say something if you have anything else to add to it.
Yeah, I can make a couple of comments. First, before I forget, I just want to thank Dr. Verma. That was a terrific review and very concise. So thank you for doing that. I think it's important to understand that low risk is not no risk. We see low risk people progress all the time in our clinics. And, Ray Benza's talked about this many times before as the creator of the REVEAL score, that any increase in your REVEAL score of even like 1 point increases your risk of a significant event by anywhere from 10 to 20%. So even if your REVEAL light score is 3 and it goes to 4, that's not good. And so I think we have to be careful, and these boundaries we've set as low, intermediate, and high risk aren't, written in stone. And we clearly know there are patients within low risk that have worrisome looking features in imaging that I think, and the Europeans, as Sandeep pointed out, have listed in the risk table some of these various measures, whether it's RVPA coupling, stroke volume index, ejection fractions, that I think we can fall back on to try to help further parse these patients' risk down, even within the low risk category. So I think that, and then finally, let's not forget that we have a drug now that even on very mature patients, we can see a tremendous hemodynamic response. I mean, in Stellar, we saw a mean PA pressure drop on average of 15 millimeters of mercury. So I think that the ability, another tool in our toolbox, helps us sort of maybe be a little more aggressive and provocative.
Yeah, I agree. And thank you for this beautiful discussion. I think our proposed algorithm tried to implement the scores that are an important tool, but they're not all and beyond everything. You have to look at the patient, and you have to look at other features of severity of the disease, such as imaging. And I say that as a humble pulmonologist who trusts our cardiology colleagues, such as Mardi and the group, to better define the high-risk features on imaging for the function and the size of the right heart. And that's a complementary method to the scores such as the REVEAL 2.0 or LIGHT 2. And I'll give you an example. So let's think about a 25-year-old patient with idiopathic PAH who starts off with severe hemodynamic impairment. She's like intermediate high risk, but she walks far at baseline, and her right ventricle is severely dilated with this impressive tricuspid regurgitant jet. Then you put her on therapy, and her right ventricle after 3 months has not progressed much. But she walks further, her NT-proBNP has come down some, so she moves from the intermediate high to intermediate low, or from intermediate low to low. Do we not take into account that her imaging on the right heart is still impressively abnormal? And that's what we tried to suggest to the practitioner, to take into account not only the score, but also extra features of the disease to make it more particular and more personal to that patient.
Yeah, and I think that's one of the aspects that I like the most about your paper. And again, I have a bias. I really like the paper all of you wrote, and that's part of the reason I wanted to discuss it. I'm blanking on a prior paper that showed patients that will have progression of disease. I remember they described findings on cardiac MRI that may suggest which patients are going to progress over time. And certainly the proposed algorithm goes in that line.
Paper, that before a walk distance or clinical deterioration happens, the RVEDP starts to go up. He was doing serial MRIs. It's Anton's paper. Can't remember who was.
Anton's, yes.
Yeah, it's published a while ago. So
yeah, it's about 10 years back. We also published that RVEF on MRI was a predictor of hospitalizations and outcomes over any of our other objective measures. So the function of the right heart makes a difference.
Yeah.
Now,
And
Marty,
sorry,
go ahead.
Yeah, I think the limitations of our risk scores, all of them, is the lack of imaging information on the right heart from the database. And that's why we don't have parameters.
But we do, right? The REVEAL risk score we looked at, we added the TR velocity because we had that in the REVEAL data set, and it made a clear difference in our ability to prognosticate. So we could just use that simple measure, which not with the estimated pressure, but the actual velocity itself.
Yeah, it's less variable. You remove variables.
Now, Mari, I have a question for you, switching a little bit. Sandeep's paper comments on the difference of the frequency of comorbidities, cardiovascular or pulmonary comorbidities, as compared to, let's say, European populations or so. How could we keep this in mind when it comes to future clinical trials? Seems that our PAH population is changing from what it used to be years ago. We are talking about older patients with more comorbidities or so. How can we keep this in mind for future trials and trying to keep a study population that will make a clinical trial finding reproducible or so?
Yeah, it's a great question, and thanks for including me with these esteemed authors. And I say that not in jest. I say that truly, my colleagues and my friends. So first, I don't know if you're going to like my answer, but this whole comorbidity stuff, I think, has gone way too far. The REVEAL paper that she showed with the wedge we included patients with wedge up to 18, and I had to present this at a clinical trials, cardiovascular clinical trials, and looked at that cohort, and actually they all had more comorbidities, and we treated them all the same. And you could argue, are they a different patient cohort, or are they just people that have different comorbidities? I think there's one thing to rule out, that they have flat out group 2 CPCPH versus, you have an idiopathic that you've been following for 20 years, which many of us on this webinar have, where they were idiopathic in their 40s that now are in their 60s and have hypertension and high cholesterol and maybe even hypothyroid, and put on some weight, and we can give them OSA. We can start adding up all these things. And so I think that as long as all that stuff is treated, yes, I think all of our older patients are going to develop left heart diastology. It's just part of normal aging, but we shouldn't let it limit what our treatment regimen is. So I'm not someone who believes that we should just try one if we truly have somebody who has PAH with comorbidities. I think that we should make sure that those patients are not true CPCPH, and it's not always perfect. And it's the same with the lung disease, right? So there's a lot of us that know the European Compara has a lot of older men in comparison to all of our other registries worldwide. You know, maybe these patients really just have, you guys are going to know better than me, that they're just emphysema and or smokers that have a low DLCO and maybe don't have a lot of emphysema on their CAT scan. I kind of feel like as our imaging gets better, we're probably going to pick up more findings. I think there was something that just came out over the weekend in chest that many of our CTs are reporting ILD when we're not looking for ILD kind of stuff. I bet that these patients aren't actually group 1 with lots of lung comorbidities. And so I think we're getting better at it. And I think that the question of the fact that there's a mix of people and mix of different comorbidities, and that it can affect how we're going to respond because you're just sicker versus they're a completely different phenotype. And so when it comes to the design of trials, like, you always want to try to be the most pure that you possibly can and limit the amount of comorbidities. But I think it's going to be impossible to completely do this where you can't have people who have 2 comorbidities from left heart disease, because it's just by nature going to happen. We're going to have those patients. It's kind of long-winded, but I apologize.
Yeah, I wonder in the next 5 years with the next World Symposium, we will have a better understanding of this pulmonary phenotype that, in my opinion, is a primary vasculopathy with maybe some emphysema, some fibrosis, but not much, but a primary vasculopathy driven by smoking.
Okay, yeah.
That we may switch its classification into group 3, even though it's not a true parenchymal, it's a vasculopathy, but it is associated with smoking, so it should be within the group 3 category. They don't respond well to the pH therapies, so they separate themselves as far as response to therapy from the rest of group 1. There are different, as far as, gender and age. So we may rethink its classification in the future.
I agree with you, Ioana. There is a paper a long time ago, and I think Mark Bear wrote an editorial on that in Blue Journal on capillary vanishing syndrome with smoking, where you do not have typical lung parenchymal disease, but just the capillaries, pulmonary capillary loss there. And if you see the recent publication in chest from Anton's group, where they did the lung biopsies and autopsy paper, I think, or post-transplant lung, they clearly showed that patients who had plexiform lesion versus those who did not, and those who did not have, they were male, older, and smoking history versus your classical PH patient who had plexiform lesion. So you're right. I think this is just a different phenotype, and it probably needs to be classified more differently and identified. And I guess it's because they do not have pulmonary capillary bed, probably that's why they do not even respond to the pH treatment. So
yeah.
I think,
There was-
go ahead.
Go-
Will. Sorry.
You go ahead. I've been talking more.
Yeah, I think it's just the challenge we have as a community is that so much of our decision making and our approach is determined by numbers in the cath lab, and we've lived and died on that sword for a long time, and we need that information to diagnose pH. But to parse these patients out, it's just not enough to look at these hemodynamics, and that's when it gets confusing. So we really have to look at the whole patient, look at the imaging, look at the comorbidities, risk factors, age, all of that to make a clinical diagnosis with support of the hemodynamics. And I think that helps us decide then who are the people that really fit more of a group 1 with comorbidities. And it's in that group, but I think that one of the reasons when Sandeep and Val and all of us got together, we wanted to address in the paper that we didn't think you had to go as extreme as the European recommendations, which that anybody with these comorbidities needs a much more delicate approach to treatment, and so that's why we suggested that, when you do that careful clinical assessment, if your impression is that this is group 1 and they just happen to have these comorbidities, you don't want to undertreat that population either. Whereas we still need to be very careful with those patients that have PH but have significant comorbidities, and it's probably a different phenotype, like that older gentleman smoking with a very low DLCO, that vanishing capillary syndrome. So that's why it's a very difficult thing to thread the needle on these issues. But and I think it's just we're slave to the hemodynamics, and that's where I think we have to look beyond that.
Yeah, I want to commend you guys on the last figure with the scales. I think that and actually how Dr. Verma explained it, which is if you have pulmonary vascular resistance, that's 12, and you have 3 comorbidities, it's still the PVR of 12 is going to outweigh the comorbidities. And so I think that was a nice sort of picturesque explanation of what you guys were trying to say. I think that came out really well and sort of made things easier to grasp.
Jim, let me have a question for you. As somebody like you who has plenty of clinical experience, but also trial experience with oral prostacyclins, any personal thoughts about the algorithm Sandeep and the group presented, and how would you incorporate oral prostacyclins, especially when we have a patient that may not want to do a parenteral prostacyclin, or for different reasons they cannot do a parenteral prostacyclin?
I guess my bias about the introduction of sotatercept is that it is a earthquake as big as ambition in terms of what's going to happen in the next 5 years. And I think that from my perspective, the really nice contribution of this article is to highlight some of the things that others have already touched on, which is that low risk is sometimes, as Murali said, not no risk, just lower risk. And by the way, that's low risk for mortality. And we should probably be thinking about hospitalization and low risk for need for advanced therapy and other things, right? It's sometimes completely wrong, right? For reasons that we don't understand. And I'm actually working with colleagues to see if we can put some numbers around, but it looks like 10 to 15% of people with clearly abnormal RV imaging that would make all of us nervous have NT-proBNPs that are less than 300. Right. So then the number is just wrong, right? It's then the risk calculation, one of the core risk variables, is just going to be wrong. And so I think thinking about those two things in the context of when we had oral treprostinil, inhaled Tyvaso, parenteral drugs, and all of those shown to produce modest benefits in the short term in terms of walk or functional class or NT-pro, but very difficult for patients to use, for sure, right? Very difficult. There are no easy prostacyclin class medications. And so now we have sotatercept, which has a side effect profile that's truly enviable, right? It's not a perfectly safe drug. There's not no problems. But with regard to important thrombocytopenia, probably 3%, somewhere around that. With regard to clinically important bleeding, but not death, somewhere's in the 4 to 6% range. And with regard to the common side effects that all the prostacyclin class drugs have, essentially nothing. So I think, when you're talking about people who previously were on the lower side of the risk category, not no risk, and maybe even falsely low, now we have a drug that we can introduce that is very easy for most people to use. And as Murali said, produces a degree of internally consistent benefits that blows away any other registration trial that's placebo-controlled ever published. So for me, this paper takes a step in the right direction for clearly prioritizing sotatercept until the Hyperion trial gives us a very clear answer on that.
I don't know if you guys actually, though, said that, I'm asking the authors, that we shouldn't be using prostanoid, especially since in Stellar, I think it's like 60% are on triple therapy, and of those, it's maybe 40 or 50% are on IV. I think it's basically saying that we don't want to rest on our laurels, even if you're low intermediate and you have imaging issues, meaning like RV is dysfunctional, that there's definitely a role for sotatercept, which is, I think, stellar patient population. I mean, maybe I'm not interpreting your study, your commentary correctly, Jim. Like I feel like sotatercept has been shown on top of dual and triple therapy, and I think you mentioned that the Zenith study closed today or hit its interim analysis, and that's what was reported. So we don't have all the data, but clearly it was helpful in high-risk patients or intermediate high-risk patients, right? But I still think there's a role for prostacyclins.
Of course. What I meant is that we can introduce a drug that is well tolerated at a much earlier time point. And I think that is going to influence people who make therapy more palatable for a person who says, well, your number says I'm low risk. And I say, well, your RV doesn't say you're low risk. And so the imaging emphasis is very nice. And then you can say, so you're falsely low risk or you're not no risk. And I am concerned about you. And now I have a therapy that's much more tolerable than anything we've had before. And I think that's what Roberto, that's my direct answer to Roberto's question, is how I frame this in terms of my own treatment philosophy vis-a-vis oral treprostinil or inhaled Tyvaso.
Yeah, Marty, I mean, every part of the algorithm that we went over a few minutes ago, that where you have the inklings of someone who is on the high risk end of the spectrum, or even intermediate high risk after initial therapy, the parenteral prostacyclins were either as a preferred option or considered maybe an equal option to sotatercept. I don't think we imply at all that we should be using sotatercept before those agents, especially given the mechanisms of action and the potential longer time before the real impact of the drug, which we don't know for sure, but obviously we studied it 6 months and showed these tremendous responses. But we know our really sick patients who are falling into high risk, they need to get better quickly. So we still favor parenteral prostacyclin in all of those situations.
A question to all of you. The algorithm is a very nice algorithm and makes suggestions about talking to your patient and having a shared decision making, which is what we all should be doing. And it recommends either considering sotatercept and or a prostacyclin. Sandeep, let me start with you. Would you consider doing both at the same time? Once you are doing your assessment, they are already on background therapy, and you feel you need to add a prostacyclin, would you also do sotatercept at the same time?
Well, again, it's an individualized approach, and like when you have a shared decision making with patient, you discuss with them, and also where they are falling into that risk stratification model. If they are really end stage advanced disease, definitely our comfort level experience is much better with prostacyclin. We've been doing this for years, and also you could perhaps start and see how the patient is responding. Many times you struggle with titration of the doses, side effects, and maybe you introduce sotatercept early in those patients. Many times patient may say that, okay, well, I don't want to live with a pump and IV line. Why don't we give it a try for a short duration with an injectable drug, maybe 2 doses, and you're not seeing any response, nothing, quickly start them on parenteral prostacyclin. Again, I guess like Marty mentioned about Zenith, interim analysis result will probably enlighten all of us much more once we have more information in high-risk group. But again, at this time, probably an individualized approach, looking at each individual patient, how you want to, discuss that with your patient. And I just gave you two different scenarios how I would approach.
Murali, let's say you have the discussion with a patient and they say, Dr. Chakinala, I'll do whatever you recommend. What should I do? What's your approach? Let's say somebody intermediate high risk asking you what to do next.
Yeah, I think that it depends obviously on what they're already on, but I think if they're an intermediate high risk with worrisome hemodynamics, particularly low cardiac output and index, I would really still favor a parenteral prostacyclin agent. I mean, we've had nothing but glowing things to say about sotatercept, but let's not forget the one thing that's always hung over this drug in both of these trials is the lack of improvement in cardiac output for reasons that no one really knows. And so if you got a patient who, especially younger person who has poor hemodynamics, and that's part of why they're intermediate high risk, it's like that part of the algorithm where you kind of have that arrow pointing you, it's really more like a high risk patient. I think that's an individual I would still favor parenteral prostacyclin over sotatercept. I think if it's someone's a little different, I mean, for whatever reason, they fall in intermediate high risk with a more, closer to normal cardiac index, maybe something in the low twos approaching 2.5, maybe, and not somebody who's been hospitalized with heart failure recently. I think that's a person that you could consider sotatercept, in lieu of a prostacyclin, especially if they're not a great candidate for parenteral therapy.
Great. Ioana, is there a patient population that you may consider not doing sotatercept? Your clinical assessment indicates you need to up-titrate therapy to either a prostacyclin or sotatercept or so, but based on what we know from Stellar and some of the follow-up data from that, is there a patient group that you feel we need to be cautious before doing sotatercept?
Yeah, that's a very good question. And it goes back to, what Jim was alluded to. No drug is without side effects. And sotatercept is a drug that has potential side effects. And I think the major concern that we need to take into account is the potential for GI bleeding, especially in patients who've had GI bleeds before and not from an ulcer, but from ectatic vessels in the GI tract. I think those would be the ones that I would be worried about to start sotatercept because of the prior bleeding. And of course, there are other very more special populations if folks live at high altitude and their hemoglobin at baseline is 17 because of the high altitude and they have PAH. I will be more cautious if to consider sotatercept because we know it acts on the bone marrow, so it does have a role in increasing the hemoglobin. It's not a side effect, if you would; it's an effect. The other population that I would be cautious would be Eisenmenger's folks whom we have not studied and who also have a shunt physiology of hypoxemia with secondary erythrocytosis. So those would be the types of patients that I would be cautious. And if I were really to start a therapy, maybe start with a low dose and follow them a little bit longer on the lower dose before, I go up to 0.7.
Would you also include portal pulmonary and patients on anticoagulation,
Yes,
maybe?
absolutely, Mardi, absolutely. Portal pulmonary hypertension patients, because of the portal hypertension, they have a tendency to bleed. Only if you look at them. It's like, I'm just afraid to even touch them or look at them, and then they're going to have an episode of bleeding. But to add on an agent that may increase the risk of bleeding, they're at a high risk.
And patients on anticoagulation as well, I would say.
Yeah, patients on anticoagulation, I think we need to
watch
really
very carefully.
And then revisit the reason for anticoagulation. What's the reason for anticoagulation?
Roberto, I was going to ask my colleagues here, and then I see it popped up in the chat too. How do you guys feel about using sotatercept in PVOD, the PAH with venous and capillary involvement?
I wouldn't.
I mean, I think there's a population that maybe we should study first. They have a different flavor of pulmonary vasculopathy. Also, I think, cadence that looks at CPCPH will give us much more information on the safety of the drug on a pulmonary vascular bed that affects pre-capillary, capillary, post-capillary system.
And arguably, as I'm hesitant, I think I'm more hesitant on like a PCH than a PVOD because we're doing cadence. And because we know we don't expect that the wedge is going to rise based on our data from Stellar and longer term stuff in Soteria. But I was looking at Murali and thinking of HHT would be another one that I probably wouldn't.
Yes. Yeah.
Because I know that he has a high patient population in that. And I also wanted to say that, the cardiac output we're looking at rest. And that when we look at the SPECTRA study, we see that, we have improvement in hemodynamics and we're looking at it in exercise. And when we're looking at sort of RV reserve, and there's a lot of study now on the left side at looking at sort of pulsatility and reserve and more than just power outputs, because with all of our VADs and fancy stuff in cardiology, we're looking more at the hemodynamics. I think the drug does help with your response to exercise. So even if the cardiac output doesn't increase at rest and we have this huge drop in mean PA pressure, it's probably allowing us to go farther, right? We're walking more, we're doing more, and we saw it in our CPETs, invasive CPET on that study. So I think it does affect the output. It's just not at rest.
Jim, let me give you this question from the audience. Maida Yakub from Cedars, she has an interesting question. Probably everybody has their own opinions about it, but what are your thoughts about having someone on sotatercept and down titrating the parenteral prostacyclin?
So I'm gonna tangential first and say that I think this cardiac output question, I think we've talked a lot about this in the last couple of years since the initial report of the data. And for me personally, the fact that hemoglobin goes up so clearly across the population and in some patients markedly means that tissue oxygen delivery goes up even when the cardiac output is stable. And our hemodynamic and physiologic systems are so geared towards equilibrium. I've got to believe that there are mechanisms that regulate this incremental drop in pulmonary pressure, a rise in hemoglobin, and say, well, my cardiac output doesn't need to go up. So there's probably some incremental increase in cardiac output when the pulmonary pressure drops and the PVR stays the same and the hemoglobin goes up and tissue oxygen delivery says, oh, I don't need it anymore. And so I think Marty made a comment about the SECTRA and when they looked at the tissue oxygen delivery, it clearly rises enormously, right? So I feel like the cardiac output thing we need to think about as an equilibrium structure, and this tremendous drop in mean PA and consistent rise in hemoglobin that as Ioana says, it's not a side effect, it's an effect. It's a part of the drug's mechanism of action almost clearly. So I'm less concerned about that. And that is why it by the way, doesn't negate Murali's observation that if you really want the resting cardiac output in a shock patient to go up quickly, that sotatercept's probably not a drug for that, right? So parenteral remains a drug for that. But in this, that relates to this question about who could come down and who doesn't, who might not need drug. honestly, Murali and I have talked an awful lot about this since the initial ACC meeting where we all embraced this data with such excitement. And unfortunately, Merck is not embracing our ideas with much excitement. And Murali and I have tried mightily to talk the company into doing something like this. My idea would not be to start with the parenteral folks, because I think that the parenteral folks, we've studied a lot over the years, and transitioning them off drugs is a neat trick. And even when it works, it's a neat trick. But I think I would start with the folks on 3 milligram TID of oral tree or 4 milligram TID of oral tree. And in fact, we're doing some of that in Rochester. And I think that in our experience, if you have somebody who's on a relatively lower dose of oral tree, that's somebody who's ripe for considering a switch to sotatercept. And we have some of those experiments in progress. We're doing them very slowly. And I'll say with humility that Irene Lang would tell me that you can spend 6 months or 9 months off of a parenteral drug if you've been on it for 3 or 4 years, and the bomb won't go off for a while. So I think whatever experiments we do, we have to regard them as experiments, since it looks like, at least at this point, Merck's not interested in supporting a company-sponsored idea. I think it's very reasonable to consider. We're doing it, but you have to really regard it as a very careful experiment with, frequent NT-proBNP follow-up, early imaging, and a repeat catheterization. And we're cathing all these people before we're doing it.
I mean, I think it's a balance between their side effect profile as well. We've seen that with sotatercept, that their sort of prostacyclin side effects or just vasodilatory side effects increase sometimes, and so then you might down titrate. But I think that when patients shouldn't go on sotatercept because they think that means they'll get off of their IV. I think that's really what needs to be said. As far as, doing it in a controlled setting, it's going to be up to the investigators, but I wouldn't advocate doing that on everybody. I mean, if you have near normal hemodynamics, then it's just like any other drug that you're coming off of IV. Their hemodynamics are normal. Patients may or may not want to do that kind of swap.
Marty, with sotatercept, it's a new reality, even for clinical trials. We are having, where I practice, more and more difficulty making trials attractive to patients because they all want to be on sotatercept. How do you see this affecting the way we do newer trials over the next few years?
Yeah, I mean, it's a great question. I think that a lot of the ongoing trials are already thinking about amending, or if not amending, their protocols to allow folks that are on it at a stable dose. I think it's going to change the bar a bit, and we're probably going to have to be more creative in the way that we do things if many people are going to be on sotatercept. Now, realize it's not approved everywhere, and it is costly. And so it's quite possible that not everybody will be on sotatercept. But I do think that it's, we're going to have to look for other measures of improvement. I think that we're not going to be able to do the same trial over and over again. And I think that it is setting the bar higher with this interim analysis being positive and showing that we're improving events in patients that were really sick. Like, this is great. I mean, maybe we can delay lung transplant in really sick patients, right? Like it can really change sort of the really sick, and then hopefully we'll have some answers on the prevention. I'm not answering your question very well because unfortunately we don't have a lot of really good markers that the FDA is going to use as surrogates for clinical trial. And so I think we're going to really need to find something that can cure it. But I also think that we're going to have to look on top of sotatercept is really what's going to happen. I mean, we can't ignore it.
Sandeep, any closing points? Once again, beautiful paper, very provocative. I think we all agree on most of the points.
No, I thank you, first of all, inviting all of us and discussing this paper. And I don't think I have any specific closing points, but I think one thing which I just want to point out in the algorithm, we highlighted at every place about shared decision making. And I think that's very important because that includes the patient perspective into it. So no matter what, yes, science is one side, but then the other side is there are people who have to live their everyday life. So that is very valuable and important thing to be discussed with patients, what their expectations are. So I think that's just my concluding remark. But I would let my colleagues say anything else I have to add.
Murali, any final comments?
I echo Sandeep's comments. It's really greatly, I mean, it's an honor, appreciated that you guys chose to discuss it. I think one rewarding thing about this is obviously as these kind of projects go, we started talking about this quite a while ago. I mean, probably close to a year ago. And then when we had this published, I think Sandeep and I were sitting next to each other in Barcelona and breathed a big sigh of relief when the World Symposium's treatment algorithm was put up there. And it basically mirrors, they did in a more concise way, but I think the same concepts were there. And we know that that's really geared towards a more global audience, but it's nice to see that we were kind of had a premonition that this is the way I think we in the US are thinking and acting. And it seems like that's what the World Symposium sort of said too a few months later.
Ioana, any final comments from your end?
Well, I think, the paper tried to gear the recommendations for our US patients and for our US providers, and include the aspect of comorbidities, that it's highly prevalent in the US, and try to specialize the treatment based on our experience in the US.
Well, I guess we will have to meet again, maybe when CNEF is published or so, but there are so many things that we still need to discuss. We need to talk about the disease-modifying concept that everyone keeps talking about, if that's real or not, and also if at one point we will do upfront therapy with the activin signaling agents or not. But thank you all for taking time on a busy Monday. Thank you, Divya. Really great presentation. Okay. Thank you, everyone, again. We'll be together next time. Thank you, everybody.
Thank you, everyone. Have a wonderful Thanksgiving, everyone. Bye-bye.
Thanksgiving.
Take care. Thank you, guys.